title. Unfortunately, I've got a bit of a long title. I used to be the CNS team lead, but as you'll know from the presentation, we have other members of our team now, so we're trying to be all-encompassing. What this presentation is about is just really telling you a bit about who we are, what we do, and how to contact us. You should have our contact details in the booklet. I think a couple of the teams may be missed off there. So if you do have patients, I think head and neck cancer is on there. So if you do have patients, please just contact any of the other numbers. My contact details are at the end of this as well. So we're very much available for questions and happy to accept emails. So I'm the line manager for the site-specific cancer CNS team at the Royal Berkshire Hospital. This is how we're divided up. We very much work within teams. Each of the cancer sites will have a team of specialist nurses and support workers who then link with the consultants, the wards and the other teams. And I should say that I work very closely with Mark and with Catherine, who spoke earlier. Catherine and I obviously work very closely with the breast team, so we have a very close interlinking team. What I should say about this, although it looks like a huge amount of staff, they're not all full-time. So I do have 28 CNSs and 11 support workers, but as I say, not all full-time. We have about 3,000 new patients per year that we will see, a large caseload of ongoing patients. Again, Catherine was mentioning earlier about discharging patients. It's very difficult. So, we don't, for a lot of our patient groups, they have ongoing problems, they have long-term problems from their treatment. So a lot of my team will have a caseload of patients that they are looking after. We also have the OFU or PIFU services that we run, and obviously you had a presentation about breast earlier. We have colorectal, open access follow-up service. The urology, skin and lung team run nurse-led clinics. We're hopefully developing open access for urology, but that's probably more than another 3,000 patients a year that the teams are seeing, often independently. So it's a big old team. What I wanted to do, first of all, and they are other specialist nursing teams that we tend to work with in the hospital. So just to give you an idea of all the different teams that we might link with. And then what I wanted to do was to show you my lovely colleague Lisa. I don't know if you can see her. I don't know if that's going to. They stick to the Wi-Fi. This was a presentation that Lisa did for the Thames Valley Cancer Alliance a couple of years ago for patients and the multidisciplinary team and what we do and how you might meet us. And I have got the link, so I can at least play it. Lisa is our gynae cancer CNS, and she started at the Royal Berks 21 years ago, as did I. So we've both been around for a long time. I should say I'm a CNS by trade, and I've worked in various cancer sites at the Royal Berks. But here's Lisa talking about what being a CNS is all about. If you can do.
As a CNS, I generally get to meet patients at around diagnosis, and this is a very frightening and a very vulnerable time in their lives. My role is to support these patients, and that can be through provision of information, it can be support with their side effects, treatment or treatment options, to do with their symptom
sorry about that. Didn't work quite as well as I wanted. But
You sent the link, Vicky.
I will, yeah, I'll send the link. And I just wanted to play that because, well, for a couple of reasons. First of all, just to say how proud the team are to do the role they do. It's a fantastic role, and how proud I am of them. I think Lisa also undersells it a little bit, but not undersells it, because obviously the key part of our role is looking after patients and supporting them, but we do a lot of other things as well, and hopefully the next slide will demonstrate that. This one more. Yeah, so this is a slide, this is actually about 14 years old now, from the Department of Health, working with Macmillan, looking at what CNSs do. It's still very relevant. I've sort of gone round it and just tried to look at what within each part of it we are doing at the RBH. And I suppose the main thing that Lisa was talking about is we're meeting patients at or near to diagnosis, which is, as she says, a really scary time. Offering support, information, contact details. All patients will get our contact details when they're diagnosed, or they should do. And we depending on which cancer site, which cancer type they have, will depend when they meet us. For example, if a patient with a brain tumour who's come through A&E might meet us at that point, whereas somebody who's come through on a pathway where they've had bleeding and being diagnosed with bowel cancer might meet us a bit later on. But all patients should have our contact details. We do a lot of signposting and a lot of referral, and run support groups, and as I said, we have an ongoing caseload. We're part of the core MDT team, and it was interesting with, it was Karen, wasn't it, when you were talking earlier about the patient with the partner with dementia. That was one of the things I wanted to flag up actually, is the CNS is often the person at the MDT who is flagging up the social situation for the patient, and I'd had an example as well about a patient whose wife had dementia, and at an MDT I was attending, we really had to sort of flag that up to ensure that the care plan for them took into account their social situation as well. So that's a really important part of our role. And obviously, as I put there, linking with primary care. I think today's been great. It's been really nice to come along and talking to people at lunchtime. And I think if there's one thing that's come out of it, a lot of us have been saying that it would be great if we could link better, because a lot of us are doing very similar things and reinventing the wheel. So it would be great if this can develop further. CNSs have got a lot of knowledge of their cancer sites, and as I've said, you've got our contact details there. If you do have queries around patient care or things that you're not sure about, please shout. A lot of them have got experience either through working in oncology or working on wards, and then coming into oncology, and we do a lot of academic study as well, so they're a very good resource. We all do advanced communication skills training. Talking to people with cancer, as you all know, can be really, really difficult, and I think I know within my team we sometimes forget. I think my team sometimes forget how good they are at doing that, and often they'll go to the wards to see a patient, and everyone's very upset on the ward, and everybody says that they don't know they've got cancer, and actually just being able to sit down with somebody and talking to them about what their diagnosis is and what it means to them is really important. That also requires a lot of resilience, and I think that's very much part of my job, is working with my team to support them and looking at ways that we can support them. As we all know, healthcare isn't getting any easier or more funding anytime soon, so it's about looking at what we can work with and how we can support ourselves and each other. HNAs, again, as we talked a lot about earlier on, we have targets to meet. We are not quite at those targets yet, but we're working towards our HNA targets, and again, talking about linking, it will be really useful if we can maybe link up and work out how the information that we're sending out is actually getting to you. talked about PIFU and OFU, and talked about Ascend earlier. One of the things that I'm involved with at the moment is looking at data collection and how I can demonstrate the work my team are doing, because that isn't always obvious, so that's something we're working on. Telephone triage as well is important. Talked about my team having a lot of academic knowledge. We have prescribers, a lot of them have done masters and history taking, and that very much feeds into the nurse-led clinics and a lot of the work that they do with those. And then I just put a few things just at the end there. Patient safety is a really key part of what the CNS does. In many ways, getting patients into hospital or keeping them out of hospital, but making sure that the right teams in the community are looking after them. There's a lot of evidence coming out now around improving outcomes, and patients who don't have a CNS actually having worse outcomes. And something that I feel very strongly about is about empowering patients, and that's, services like OFU, it is all about empowering people, but making sure that they have the right knowledge to be empowered. These are our cancer support workers, and these two here on the right are Anna and Paula that Catherine was talking about earlier, who do the support for the breast OFU service. They're absolutely fantastic, our support workers. They're a relatively new recruitment. We did have a support worker back in 2015, but the last 2 or 3 years it's really expanded, and we've got quite a few in the team now. And they're fantastic. They do a lot of support for patients on telephone. I think very similar in many ways to the care coordinators and the social prescribers. There's a lot of that goes on as well. So again, we're doing very similar things both in primary and secondary care. And that's it for me. That's my new favourite slide. That's an empowered patient. Has anybody any questions?